Hi everybody and welcome to our module on renal embryology. In terms of germ layers, the kidneys are derived in utero from the mesodermal germ layer, and what you have to understand kidney development in utero is that 3 embryonic renal structures form in utero, but the first 2 degenerate and the third one goes on to become the adult kidney. The first kidney structure to form in utero is called the pronephros. This structure forms and then degenerates by week 4 early in the first trimester. The second kidney structure to form is called the mesonephros. This structure functions as the interim kidney in the first trimester, and then it degenerates, although it contributes to the vas deferens in males. The final kidney structure is called the metanephros. This is the structure that goes on to form the permanent kidney. It appears around the 5th week of development, and then it continues to develop into the kidney all the way through weeks 32 through 36 of gestation. And just so you have a picture of this in your mind, in utero there is a structure called the mesonephric duct. This is a structure that's very important to development of the genitals in males, and I talk about it a lot in the reproductive genital embryology videos. But the same structure forms in utero, and it has one end called the cranial end that's towards the head, and it has another end called the caudal end that is towards the tail. So up at this head end, you first have a renal structure form called the pronephros. It then degenerates. Then a second structure forms and it also degenerates. And then finally, down here at the caudal end, we're going to have formation of the metanephros, which goes on to become the permanent adult kidney. So there are 2 key structures involved in forming the permanent adult kidney. The first one is called the ureteric bud. This is an outgrowth of the mesonephric or Wolffian duct, as I just showed in my drawing. It grows out of the caudal end of the mesonephric duct, and it will eventually give rise to much of the urinary collecting system, like the ureters, the urinary pelvis, the urinary calyces. Also, in terms of the nephrons, it gives rise to the collecting ducts, and I'll talk more about that in a minute. The second key structure is called metanephric mesenchyme. This is basically just mesoderm tissue that surrounds the ureteric bud. It's also sometimes called metanephric blastema. Unfortunately, it goes by a couple of names. And this tissue will interact with the ureteric bud, and that will give rise to the glomerulus and the distal tubules, all the portions of the nephron except for the collecting duct. And as we'll talk about later in this video, if the interaction between the metanephric mesenchyme and the ureteric bud is abnormal or aberrant, that leads to many kidney malformations. So here's a drawing of the nephron, and what you have in utero is a little bud coming off the mesonephric duct. That's called the ureteric bud. And it interacts with all this tissue surrounding it called the metanephric mesenchyme. The ureteric bud will form the collecting duct of the nephron, and it will also form much of the urinary collecting system. The metanephric mesenchyme, the tissue surrounding the ureteric bud, will form the proximal tubule and all the other parts of the nephron other than the collecting duct. There's a renal malignancy called Wilms tumor, which is the most common renal cancer of young children, and you should be aware that there's a tie-in with embryology here. This tumor is caused by an abnormal growth of the metanephric blastema. That's that tissue that surrounds the ureteric bud. This is capable of forming embryonic glomerular structures, and that's what you see when you do a biopsy of a Wilms tumor. It looks like what's shown on the screen here. All this purple stuff is embryonic glomerular structures. And this type of cancer is associated with mutations of a gene called WT1, and this is a gene that is normally expressed in metanephric blastema or metanephric mesenchyme. So all this should make sense to you now. This tumor is basically related to aberrancy of the embryologic structures in the kidney, and that's why it leads to tumors that occur in young children. Some children are born missing one or both kidneys. This is called renal agenesis. Basically, the kidney fails to form. And the cause of this problem is that the ureteric bud does not develop, and it never sends any signals to the mesenchyme, so you don't get a kidney. If this happens on only one side of the body, then a single kidney will be missing, and the remaining kidney will compensate. What happens is the other kidney undergoes hypertrophy and hyperfiltration, and this will basically serve to do the work of both kidneys so that these children are born normal and they are generally healthy. The major problem for these children born with one kidney is that there is a risk of renal failure decades later. They get a glomerular disease called focal segmental glomerular sclerosis, or FSGS, that I talk about in more detail in the videos on glomerular diseases, but it's very high yield to know that if a baby is born with one kidney, that's usually because their ureteric bud did not develop. That led to renal agenesis, and years later, these children may get FSGS. Now, if both kidneys fail to develop, that's a big problem. The baby will have oligohydramnios and Potter syndrome, and we'll talk about these things later in this video. Another renal developmental anomaly is called multicystic dysplastic kidney. The cause of this problem is abnormal interactions between the ureteric bud and the mesenchyme. So if the ureteric bud doesn't form at all, you'll get renal agenesis. If it forms, but it interacts abnormally with the mesenchyme, you can get a multicystic dysplastic kidney. It's a form of renal dysplasia where the kidney is replaced with cysts. You can usually see it in utero on ultrasound. This is a picture of it shown on the screen here. There's usually no or little functioning renal tissue. It's usually unilateral and only affects one kidney, and this is in contrast to other cystic kidney diseases that are genetic in origin. Those typically affect both kidneys. If you look down at this drawing of the kidney on the right, this is the pelvis of the kidney, and this is where the ureter attaches to the pelvis. This is called the ureteropelvic junction, and this is the last connection to form in utero of the urinary collecting system. And sometimes it does not form properly, and that leads to ureteropelvic junction or UPJ obstruction. This is a common cause of single kidney obstruction. So if you read a board question where one kidney is obstructed and swollen, that could be a UPJ obstruction. If both kidneys are swollen, it's probably something else. In this condition, there's a narrowing of the proximal ureter. That's the ureter right here, very close to the kidney at the junction to the pelvis. It leads to hydronephrosis, which means a swollen kidney. This can often be detected in utero. And after birth, these children can have poor urinary flow because of this obstruction, and that can lead to an increased risk of kidney stones or urinary tract infections, and it can be treated if needed with surgery after birth. Let's take a look at this X-ray on the screen. The kidney on the left side has a single ureter draining down into the bladder, but if you look at the right side, you can see that there are two ureters that both drain to the bladder. This is called a duplex collecting system or a duplicated ureter. This problem occurs when two ureteric buds form on either the right side or the left side. It can also sometimes happen if one ureteric bud forms, but then it bifurcates during development. What this leads to is a situation where on one side of the body there are basically a separate upper and lower kidney, each with their own drainage system. This can lead to poor urine flow, and that can lead to a swollen kidney or hydronephrosis that also can increase the risk of urinary tract infections, and it's also associated with vesicoureteral reflux. So let's talk about what that is now. Vesicoureteral reflux is backward urine flow from the bladder to the kidneys. So if we have a right kidney and we have a left kidney and they both connect via the ureters down to the bladder, if there is a problem where the ureter inserts into the bladder here, then anytime the bladder contracts, instead of pushing urine out of the bladder, it will push it back up towards the kidneys. That's called vesicoureteral reflux, and it can happen if the ureter inserts abnormally here into the bladder on either side. The main clinical consequence of this problem is recurrent urinary tract infections. You need good forward flow of urine to keep bacteria out of the urinary tract. Vesicoureteral reflux is called primary vesicoureteral reflux when it's caused by abnormal closure of the ureterovesical junction or the UVJ. This is where the ureter inserts into the bladder. This often occurs in children, and it's high yield to know that this is associated with duplex ureters. If the ureters form abnormally and they are duplex, they often insert abnormally into the bladder, and that often allows urine to leak backwards up towards the kidneys when the bladder contracts. There is also a form of vesicoureteral reflux that's called secondary. This happens anytime there's very high pressure in the bladder. If the pressure gets very high, then when the bladder contracts, it will push urine backwards up towards the kidneys. This is seen when there is an obstruction to the outflow of urine from the bladder, and one of the conditions that causes this that occurs in children is called posterior urethral valves, and we'll talk more about that in a minute. You can also see secondary reflux in men who have significant benign prostatic hyperplasia. Now let's talk about Potter syndrome, which is also called Potter sequence. This is a collection of abnormalities in a fetus that is caused when the fetus is exposed to absent or decreased amniotic fluid. Remember that the amniotic fluid in the womb comes from the fetal urine, so if there is severe fetal renal malfunction, this leads to decreased amniotic fluid, and that can lead to Potter syndrome. The reason Potter syndrome occurs is because there is a loss of fetal cushioning to external forces. The amniotic fluid in the womb protects the baby from pressure from the organs in the mother's abdomen. If there's not enough amniotic fluid, all those organs in the abdomen will push on the baby. This will lead to external compression of the fetus in the womb, and the baby's face and limbs won't form normally. These babies are born with smushed faces and abnormally formed limbs. Another problem that happens is that you don't have the normal liquid environment in the lungs while they are developing, and for this reason the lungs usually don't form properly, and that can lead to severe respiratory problems at birth if the child survives. In many cases, Potter syndrome is fatal, and the baby does not survive to birth. So here's a summary of the things you can see in a baby with Potter syndrome: limb deformities, a flat face, pulmonary hypoplasia, which is poor development of the lungs, and as I said before, this often leads to fetal death. In the reproductive section, I talk about oligohydramnios, which is decreased amniotic fluid, and you should be aware that the causes vary by the trimester. So In the first trimester, which is the first 12 weeks, oligohydramnios is very rare. In the second trimester, which is everything up until 27 weeks, this is when oligohydramnios often occurs from decreased formation of fetal urine. The urine is very important in the second trimester to keep that volume of amniotic fluid up. In the third trimester, which is 28 weeks until birth, when you have oligohydramnios, it's often due to rupture of membranes. At this point in time, if the amniotic fluid level is normal, then usually the fetal kidneys are normal. And if you suddenly develop oligohydramnios, it usually means there's been some loss of amniotic fluid, commonly due to rupture of membranes. So now let's talk about the causes of Potter syndrome from a renal embryology standpoint. The first one I already mentioned earlier is bilateral renal agenesis. If that ureteric bud does not form on both sides of the body, then the kidneys won't form. This is often detected in utero. The kidneys will not be seen on ultrasound. They're normally visible by 10 to 12 weeks, and these babies usually don't survive because there's no amniotic fluid. Another cause of Potter syndrome is called a posterior urethral valve. I also mentioned this earlier in the video. This only occurs in male babies, and the cause is a piece of tissue called a posterior urethral valve that obstructs the bladder outflow. If you look at this drawing on the screen, this is the bladder, and urine is supposed to flow out into the urethra in the male baby so it can go on to become amniotic fluid. If there's a piece of tissue right here, then urine cannot leave the bladder, and that will lead to fullness of the bladder and swelling of both kidneys. And this is called a posterior urethral valve, and this can lead to Potter syndrome. This is often detected on prenatal ultrasound. The baby will have a dilated bladder, and both kidneys will be dilated as well. And remember, both kidneys are affected. We talked earlier about some causes of hydronephrosis in one kidney. In this case, you will have hydronephrosis of both kidneys. And when you see that described in a fetus, especially if it's a male fetus, you should think of posterior urethral valves. Another potential cause of Potter syndrome is autosomal recessive polycystic kidney disease. I talk about this in more detail in the video on cystic kidney disorders, but this is the juvenile form of cystic kidney disease that occurs in the fetus or in children. Cysts form in the kidneys and also in the biliary tree. Both kidneys are affected because it's a genetic disease, and if it's severe, it can cause oligohydramnios. If it's less severe, then it may cause renal failure and hypertension in childhood. Horseshoe kidney is a developmental anomaly of the kidneys where the inferior poles of both kidneys fuse. It looks like what's drawn on the screen here. You can see that the bottom or inferior portions of both kidneys are linked together. That's called a horseshoe kidney. When this happens, the kidneys cannot ascend in the pelvis, which they normally do during development, to rise up and settle in the retroperitoneum. They will therefore be lower down in the pelvis. And the reason for this is because they are trapped by the inferior mesenteric artery, and it's very high yield to remember this. When the kidneys are fused like this, they get stuck below the inferior mesenteric artery, and therefore they cannot rise up to settle in the retroperitoneum where they're normally found. So in the adult who has horseshoe kidneys, you will find the kidneys lower in the abdomen compared to normal. Most patients are asymptomatic, and the condition is diagnosed when they have a CAT scan or an abdominal imaging procedure for some other reason. This is associated with Turner and Down syndrome. It's more likely to occur in patients with those conditions. And among patients who are symptomatic, it's usually because of vesicoureteral reflux, which I talked about earlier. Remember that anytime the kidneys don't form normally, then the ureters often don't form normally, and that can lead to a setup for reflux. And here's a CAT scan of a patient with a horseshoe kidney. You can see that the kidneys are linked together here across the midline. They're also lower down in the abdomen than where they are normally found. We'll finish this video by talking about the urachus. The urachus is an embryologic structure that connects the dome of the fetal bladder to the umbilicus. It should be obliterated at birth and become the median umbilical ligament. If there is failed or incomplete obliteration, then a couple of anomalies can occur. First of all, urine can leak from the umbilicus in a newborn baby if the urachus does not obliterate. In addition, there is sometimes incomplete obliteration, leaving behind cysts or sinuses or diverticuli, and these can go on to become setups for development of infections. Here are some drawings of urachal anomalies. This is a patent urachus. The bladder here is still connected to the belly button, and this baby will have urinary drainage from the umbilicus after birth. This is a diverticulum. It's an outgrowth of the bladder from the urachus being left behind. This can potentially become infected. And this is a urachal cyst where there's a little pocket or cavity where the urachus was in utero. It's very high yield to know that urachal remnants can lead to adenocarcinoma of the bladder. This is a very rare form of bladder cancer. Usually the bladder does not develop into adenocarcinoma, but this can occur when a piece of the urachus remains behind. And classically, this will lead to a cancer at the dome of the bladder. So the classic case is an adult with painless hematuria, which is a common presentation of bladder cancer. The tumor is found at the dome of the bladder, and the pathology shows adenocarcinoma. What the question is likely going to ask you about is where did this come from? And the answer is it came from the embryologic structure, the urachus. And that concludes our video on renal embryology.